So the balance is something, what's going in and what's going out. So for calcium, here is the calcium balance in kidney disease, walking the tightrope. It's not easy. So that's what we take in. Absorption is determined by vitamin D, status of vitamin D. The bone is 89% of all the calcium is in the bone. So whatever you do with the bone, you change the calcium balance. It's not the serum. The serum is a ridiculous compartment for the calcium. Filtration is 800 milligrams a day, and urinary excretion is between 150 and 200. That's what a normal individual is doing with calcium. So if we now go to this slide, again, and I like very much this slide because you can use it for many physiological things. So you remember this decrease in GFR, the increase in PTH, the absolutely unchange of calcium throughout the whole story. Calcium is not going up slightly only in exceptional cases. Even the calcium goes down at end of the right. Vitamin D goes down and PTH goes up. And oh yeah, thank you. And we have this FGF going up. So the next is, there is a tendency, and it's not a tendency, if you measure your calcium in the urine of your patients with CKD3-4 are hypocalciuric. There is a decrease in ionized calcium, generally. As you see here, 20% of the patients with progressive end-stage renal failure have a tendency to decrease the ionized calcium. Total calcium is difficult to do. So there is a tendency to hypocalcemia. So altogether, increase of PTH, decrease of vitamin D, low calcium in the ionized calcium. This will result in what? Will result in secondary hyperparathyroidism. That's what we have in a normal evolution of a progressive renal failure. And we will see that this is not unimportant to think about that. So the urinary calcium in renal failure, that's what you find in normal patients, in normal individuals. That's what you find in CKD4, lower, much lower, hypocalciuria. PTH increases and will reabsorb calcium, because calcium, we need calcium, so we need to have a good homeostasis. And the body is, as I said, as I explained yesterday, for phosphate, exactly the same is occurring with calcium. We try to get our calcium in balance, to have a normal calcemia, to have a normal ionized calcium. So the body tries to, the PTH reabsorbs calcium, even at very late stage. Filterable calcium will be decreased in the setting of elevated phosphorus. That's something we have forgotten. And I show you the next slide. For any increase in phosphatemia, if you increase the phosphate in the serum, you have a decrease in calcium. That's a very simple physical-chemical interaction. So hyperphosphatemia directly will induce a tendency to hypocalcemia. This is very old, but it's very important in modern nephrology to think about that. Here we have the balance. Before we have a balance, we think about absorption. I went back to the old literature. You will see today, we will go back to the literature of 60 years ago, later on. This is not so much as 40 years ago. And you see here nice studies in patients with normal renal function and patients with renal failure. And that's the balance. And you see the balance of patients. There is a decrease of absorption of calcium in renal failure patients because of vitamin D deficiency. Okay, that's rather simple. The reason for that is we know now. The reason for that is FGF. FGF blocks vitamin D, and when you block vitamin D, the synthesis of vitamin D, you will reduce the calcium and phosphate absorption in the small bowel. That's the reason of the first reason why we have such low calcium in our body. And if you look to hyperphosphatemia and hypocalcemia in patients with different degree of GFR, you see that a lot of patients with low GFR have hyperphosphatemia and have hypocalcemia. Okay. So patients with CKD4, 3, 4, 5, not in dialysis, have a tendency to hypocalciuria. Not only a tendency, you measure that and you find that. There is an inadequate renal calcitriol, so you have hypocalciuria and modest hypocalcemia. There is phosphate retention, I explained that already, and all that together will of course induce secondary hyperparathyroidism. So all our patients in CKD 3, 4, 5, without any treatment, have secondary hyperparathyroidism, should have a secondary hyperparathyroidism. So, in conclusion, patients with CKD4/5, not yet in dialysis, have a negative calcium balance. They have not enough calcium uptake from the food because they can't do that because of vitamin D, etc., etc., etc. Okay. Let's go now to the calcium balance in dialysis. Difficult, extremely difficult to measure. Dietary intake, calcium binders are given, vitamin D is given, yes or no. Stool output, difficult to measure. Urinary excretion, almost no urinary excretion. Exchangeable calcium pool on bone surface is not very well known, etc., etc. Just to show you that this is a difficulty to measure correctly what is going on. But now I will go to a concept. Before I can go on, you have to show that. If we do bone biopsy in renal failure, you can have the following conditions. You can have a normal bone. This is a normal bone. The blue line, the blue is the mineralized bone. This is osteoid, and these are osteoblasts. This is normal. This is what we should have found in our patients, hyperparathyroidism. So osteoblast, very active, stimulated by PTH, a lot of osteoclastic insulae, and fibrosis in the bone marrow. That's what you find and what you should find in your patients because in end-stage renal failure. You can have adynamic, and you see that is a dynamic one. No osteoblasts anymore, almost no osteoid, so the bone is lazy and is sleeping. And you can find osteomalacia, but that's history of medicine. We found that enormously in the time from aluminum when all our patients developed osteomalacia after a certain time. Okay. The way to do it is histomorphometry. You can, of course, look to the microscope and you can have an idea, but the best way is to measure, and to measure simply the bone formation rate, which is with double tetracycline, I will not go into the details, and the surface of osteoid. And by doing that, you can easily distinguish between adynamic, osteomalacia, high osteoid, low bone formation, and osteoitis fibrosa, a lot of bone formation. So that's the way it should go. And if you go to the literature and you find what we find in our patients. When I was a nephrologist starting in the business, even before that, 72, we had the majority of our patients had hyperparathyroidism. And that's what we expected when you do a biopsy at the end of the road and in the beginning of dialysis. But what you see over the years, you see adynamic was non-existing, is becoming 60 to 40% of our patients. And I saw yesterday a slide from one of you showing that in peritoneal dialysis you have 60% of adynamic bone disease. And it's true. Several studies have shown that the majority of the patients in dialysis have adynamic bone disease. We had a fellow from Macedonia, a small country in the Balkan, and he stayed with us during 1 or 2 years, and he's a very good guy, and he went back to his country and did a biopsy of the bone in every patient coming to dialysis. You can do that in Macedonia, not in Belgium anymore. And I don't know if you can do that in Egypt, but you never know. You have to try. But this is a wonderful sample, because most of the studies on bone biopsy are biased by the sample. You do bone biopsy because of indication. He did systematically, and that's of course important to see. And when he found that the majority of the patients had adynamic bone disease on normal histology after 6 months in dialysis. Let's go back to the literature. Maluke took everything together, and he found that hyperparathyroidism, which was very prevalent when we were young, became an exception in end-stage renal failure in dialysis. And what is now going up is adynamic bone, became the major issue in the dialysis patients. So we have now a complete unexpected spectrum, because what we should have is hyperparathyroidism. I have given you the evidence of that. But as soon as you are in dialysis, you see something else appears, and it is adynamic bone disease, which is against the normal physiological thinking of pathophysiological thinking of our patients. So that's I want to give you as an introduction. So what is the reason for that? And now I develop a concept. We nephrologists have installed a dramatic positive calcium balance in our dialysis patients. We have been educated, and it's correct, that our CKD3/4 have a lack of calcium, or not absorbing very well calcium. So we thought that by treating them, we need to give them a lot of calcium. And we did that. And what is the reason that there is an enormous calcium load in end-stage renal failure in dialysis patients? First of all, you have no renal function anymore. So you lose the only tissue, organ, which is organizing the balance, is the kidney. calcium is not disappearing in the respiration nor in the gastrointestinal tract. It only disappears, regulated in a very complicated way, in the kidney. So you lose that. The second thing you do, you give administration of vitamin D. And I ask for your attention. This is an intestinal cell. This is the lumen, and this is the blood side. And you see what is vitamin D doing. If you give vitamin D to your patient, you will do many things, because vitamin D is very powerful. But the thing for us important is that it increases TRPV5 and TRPV6. What is TRPV5? These are two very important calcium channels, which are present when you give vitamin D, and which are absent when you have no vitamin D. So your vitamin D will increase dramatically the absorption of calcium in the bowel. Normally you absorb paracellular, a certain part, and everything if you have no vitamin D, but if you have vitamin D, you will absorb through the calcium channels. So they are stimulated by vitamin D. So if you do that, you increase dramatically by 30% your calcium absorption. We use calcium and non-calcium containing phosphate binders. And now I will go into a story I was not aware of, but you will see. When you give a phosphate binder, what is happening when you give a phosphate binder? When you give a phosphate binder, you will eliminate phosphate, but that's the reason why you give a phosphate binder. Phosphate binder binds phosphate in the foods and eliminate that by natural way. But what we have forgotten, and I was not aware of, but I will give you the evidence, you increase dramatically the absorption of calcium. As soon as you give a phosphate binder, you will increase the calcium absorption. And this will result, when you have still some kidneys, in elimination of phosphate will dramatically decrease in the urine, because the balance is very negative. You eliminate all by stool, so you will not eliminate by the kidney, but you will increase the urinary calcium. Let's look to the evidence. This is old papers from 1950, it's almost 64 years ago, a beautiful balanced studies showing patients receiving amphogel, which is aluminum. It's a non-calcium containing phosphate binder. It goes along with, after a few days, a dramatic decrease in phosphate in the urine, because aluminum is a very powerful phosphate binder. But what is important for our discussion is the increase in calcium in the urine goes from 180 to 400, so doubles the calcium excretion. So any phosphate binder, non-calcium or calcium, is increasing the calcium balance. Again, another study in the New England Journal of Medicine of 68, that again is shown that indeed the calcium absorption by calcium chloride, control value and aluminum related tablets, it goes from 45 to 75. So any phosphate binder increase the calcium absorption. And finally, we use calcium in the dialysate, and if you look to the figures I collected from the industry, you see here the concentrations of calcium, ionized calcium in the different baths. You see that we still use, some people use 175, even 150, and if you do that, you have always a positive calcium balance, as shown here by Mu. If your dialysate is 1.5 and 1.75, you are almost continuously in a positive calcium balance. In other words, to summarize, what I wanted to say is we have at least 5 reasons why we nephrologists have installed in our patients of end-stage renal failure, starting dialysis, an enormous calcium load. What is the consequence of that? If you go into that calcium load, you install a relative hypoparathyroidism. Your PTH will go down. And we all know that for a normal bone turnover, we need, at least in dialysis patient end-stage renal failure, we need 150 to 200 picogram per ml to have a normal bone turnover. As soon as we go down to 150, we slow down the bone turnover, so our calcium load induces a relative hypoparathyroidism. And that hypoparathyroidism will decrease the bone formation. So we have induced a new bone disease because of our calcium load. And for the arguments I have given you, which is evidence-based, because all that is data, hard data from our clinical literature. You can easily make the diagnosis. You don't need a bone biopsy. We did this study, and also Urena did that in France, and we had exactly the same results. If you combine a PTH below 150 picograms per ml and you have a Boone alkaline phosphatase, which is low normal, the chance to have adenoamic Boone disease is 90%. So this is a good sensitivity, specificity of 95. So this is a test which is acceptable for clinical medicine. So if you have that, and this is Dobbs, for example, Dobbs of 99, 2003, well, almost half of all the patients in Dobbs have an adenoamic Boone disease. So this disease is very prevalent and very frequent in dialysis. Now, what is the consequence of that? When you have an adenoamic Boone disease, your plasma calcium efflux is decreasing dramatically. Your calcium accretion, the fact that calcium is built in your bone, is dramatically going down, and the calcium retention is also going down in the bone. So the calcium is not going to the bone. Where is the calcium going? Because calcemia remains normal. Well, the calcium goes to the vessels. And here you have it. We looked, and this is literature in Jason of a few years ago. London looks to the arterial calcifications and bone histomorphometry. And what he found, if you have low PTH, then you have grade 4 of calcifications, meaning that hyperparathyroidism and adenoamic bone disease, as in these graphs, are going along with a high incidence of very high level of calcification. So the danger of having this calcium load, having this adenoamic bone disease, is that you will develop much faster vascular calcifications. It's due to iatrogenic approach of our treatment of our patients. Another paper of his group showing again the aortic calcification, aortic pulse wave, and you see this is hyperparathyroidism, and this is when you go back and you go to the low bone turnover, you see that the aortic calcification is going very fast, very hard. And the aortic pulse wave is very high compared to those with normal bone turnover. Again, and then again, another study by Raki some years ago, where you see that adenoamic bone, when calcium carbonate is used, you see the aortic calcification going up very quickly compared to patients who who have active bone, who have dynamic bone. The incorporation of the calcium vascular calcification is much slower. So the message here is that our adenoamic bone condition we have created in our dialysis patient is something very serious, because the development of vascular calcification is speeded. And here you see a curve of PTH and mortality and risk. And we all know since many years that hyperparathyroidism can go along with some risk to develop that. But what we have not forgotten, and this was very nice to see that, and this confirms what I tried to explain, that if your PTH goes down, the risk is comparable as if your patient had a very severe hyperparathyroidism. So the adenoamic bone, low PTH, is a condition of developing vascular calcification and going along with the risk for mortality. So what is happening, and I go now to the 5 last minutes, what is happening when you have a low bone turnover, low PTH, your calcium phosphor cannot incorporate, is not well incorporated into the bone, so it goes to other sides, and it goes preferably into tissues and preferably into the vessels. And I will very briefly approach that, the physiopathology, because it helps us again in the understanding of what I tried to explain. This is the famous calcifications we have. We all have that when we are 60 years of age, or even younger. We develop plaques in our vessels. But our patients develop that, the media calcifications, the Munkeberg media calcinosis, which is very typical for renal failure. There is an enormous list of factors which are disfavoring the development of calcification. I will not go into that, but I will go into the most important, most early ones. We now know that the muscle cell, the smooth muscle cell, differentiates into an osteoblast, because this cell, which is a muscular cell, starts producing alkaline phosphatase, calcium binding protein, etc., the whole machinery to start mineralization. And this is due, in the first phase, to hyperphosphatemia and hypercalcemia. Hyperphosphatemia alone cannot do that. You need hypercalcemia, you need a higher ionized calcium load together with phosphatemia. What is the evidence for that? Is that very solid? Well, it is solid. If you look to the early phases of mineralization, that is production of microvesicles. The osteoblast starts secreting small vesicles in its surrounding. And it is those vesicles who mineralize. with calcium and phosphate. So if you look to microvesicles and apoptotic bodies, which are the two first things osteoblast is producing, you see, when you incubate those with high phosphate, you see some increase of this mineralization. But if you incubate with the combination of calcium and phosphate, you see the microvesicles start growing very fast. So the combination of the two is extremely important. We looked there's a paper we published together with a Dutch, a German group, and we looked to our patient, is that reality, all that in mouse and rats, etc.? These are vessels from our patients, taken during the biopsy of putting a shunt or whatever during transplantation. And you see here, beautifully, I will show you one thing. This is electron microscopy this is a smooth muscle cell, and surrounding in the smooth muscle cell are full of vesicles which are positive for calcium deposition. And if you look more carefully, you see first the nature of microvesicles around the smooth muscle cell. Some of the microvesicles start having some precipitation, and after some time, the whole macrovesicle is all precipitation. So that's reality. This is not fiction. This is what's happening in our dialysis patients and our end-stage renal failure patients because of our calcium load. And to convince you finally more, this wonderful study of Prof, very recent one, showing again that if you incubate with high phosphate, or you incubate with calcium phosphate, and you look to vessels of patients, this is again is human material, and look to the scale, this is up to 600, this is to 2000, that the combination of calcium and phosphate has a dramatic effect, much more higher than anything you can see in end-stage renal failure vessels of patients. So there is a precondition of the dialysis patient in developing this fantastic phosphate calcifications in this patient. So the calcium load in dialysis patients is increase in ionized calcium, relative hypoparathyroidism, low bone turnover, less incorporation of calcium in bone, and high risk of vascular calcification. So what can we do? What can we do? We all know that patients in end stage in the failure develop much faster. And the most convincing is this nice paper of Nakamura. He studied all the arteries, and he did it with patients without CKD, 1, 2, 3, 4, 5. And you see here, all these figures are rather low, but once you have CKD and dialysis, there's an explosion, factor 10 to 20, in the speed with which they develop vascular calcifications. And that is not true. And what can we do? How can we limit that? And that's the end of the story. We can limit the use of calcium-containing phosphate. Of course, it's sometimes difficult in countries like yours, but we can discuss that during the discussion. We should avoid, and that you can do, we should avoid adynamic bone disease. You should follow the PTH and bone alkaline phosphatase. And if these two factors are indeed indicative of adynamic bone disease, you change your policy. And this is easy. The adynamic bone disease is a reversible process. If you slow down the calcium content of your dialysis, you see nicely the PTH going up and bone phosphatase is going down. So you can reverse that. And I have the evidence for that. I don't know if I have a slide, whatever. So we can also decrease the calcium concentration of the BAT, and you can finally use non-calcium containing phosphate binders. So what can we do? Reversal. Here is the reversal of the adynamic bone, clearly shown here by changing the calcium in the dialysate, and the PTH goes up. But I want to end with some considerations on non-calcium containing phosphate binders. It is, of course, not directly evident for you, but it's important to have at least the message and to think about and to maybe use it from time to time. This is sevelamer. This is non-calcium containing phosphate binder. You see, if you compare sevelamer with calcium, the progression of the calcification, the coronary artery and the aortic calcium is much faster in the calcium containing versus the non-calcium containing phosphate binder. So that's hopeful. That's already showing. And there is one study already with sevelamer showing that the mortality in dialysis patients on this particular non-calcium containing phosphate binder is less. But I want to give you a story of a recent research program we have in our group, showing that if you look to the two calcium-containing non-calcium-containing phosphate binders, this is sevelamer and this is lanthanum phosphenol, and you look to the fractional excretion, and you see with sevelamer there is indeed an increase of the fractional excretion of calcium, which is what we expect because it's a non-calcium-containing phosphate binder. But to our surprise, the calcium in the urine with lanthanum decreased. And this was against all what we in the meantime have accumulated as evidence. Whatever calcium of non-calcium containing phosphate binder you use, you also go up with the calcium. This calcium goes down. And I will give you the explanation for that. I found a paper in GPC, and this was a beautiful paper. And I go back here to my TRPV5 and TRPV6. What those guys did. This is a very good group in Nijmegen from Hunderop. They used cells, intestinal cells, and they stimulated intestinal cells with 125. So the calcium channels were going up. They were ready to absorb calcium. And they submit the cells to all the anions and cations. And here's the anions, lanthanum, cadmium, etc., and verapamil as a calcium channel blocker. And what they saw is that all those drugs decreased the calcium absorption, and the most important one was lanthanum. Lanthanum blocks for 80%, 90% the calcium channel uptake through the calcium channel. So that's maybe that the explanation why in our patients we found a low calcium in the urine, because the calcium absorption is decreased. So we did the studies, the appropriate study to do. We took the rats in a metabolic cage and we put them on different phosphate binders, sevelamer, calcium, and lanthanum, and then we studied them, and then we had a washout, and then you see the most important results is serum ionized calcium in the control group, of course, was not changed. Serum ionized calcium in the calcium group was, of course, increased during the treatment. With sevelamer, we also had an increase of the calcium, and with lanthanum, we have no statistically any change of the calcium in the ionized calcium. And we did again that in renal failure rats, and we found that the urinary calcium was high with sevelamer, what we expect with all the phosphate binders, but the urinary calcium with lanthanum was absolutely unchanged. So in other words, this type of phosphate binder, a non-calcium containing phosphate binder, has a much lower effect on the calcium absorption than any else of the rest of the calcium containing phosphate binder. So what is my message? What should we do? We should limit the calcium load in our patients. We should think about that, because we give too much calcium, and we have, of course, we need calcium, but we have given too much. So we can do that by using non-calcium containing or aluminum for a certain time period, and we can come back to that in the discussion. We can ourselves look for adenomic bone disease. You do not need a biopsy for that. Just do PTH and bone alkaline phosphatase, and you have the diagnosis, and you can play with calcium in another way. We can decrease the calcium concentration in the dialysate, and of course we can also play with the diet in the daily use of calcium in the day. So these are the names of the guys and the people of the lab where we did all those studies. Thank you very much for your attention.
Thank you very much, Prof.